You can use the key terms is also in the reading. You can also go to the glossary. The glossary got the key term, all in the reading.
Okay. All right, class. Let's see here.
What I did is, I went by, I did each word, I said, oh, this, oh, like this. Let's stop with the word. I see, I did something.
All right, you guys. So we're going to talk basics of insurance, chapter 3, basics of insurance. So pretty much we talked about the other day. There's two types of insurance plans. We have the commercial insurance and we have the governmental insurance. Okay. The governmental insurance would be like Medicare, Medicaid, and all of its products. And we'll talk about that. You know, products like CHIPS and STARS. Okay. Champa, Champas, and TRICARE. Okay, so those are all of your governmental insurance. Now, the reason why I have it written like that, as far as like the governmental insurance, is that you can understand that when you work in the real insurance industry, they're going to talk, is the insurance governmental or commercial? If it's commercial, they're speaking of insurance plans that are like Aetna, United Healthcare, Molina Health, Blue Cross Blue Shield, and Cigna. And they have products. So let me erase all of this, what we just talked about the other day, and let me make it a little bit more simpler. Okay? So I'm gonna erase this. Did anybody have any questions for me from Wednesday night? No? Okay. Did y'all get a chance to start reading your chapter 3 or look at it or look through it?
Where I looked through it in my head, I think so.
Okay, great. What did you think about the assignment?
With the key terms and the abbreviations.
Okay. Okay. All right. Now I'm gonna angle my camera back over this way. Kind of start up under here. Okay, so you have insurance plans. Here are some of your insurance plans. 1, 2. Okay. Commercial. Okay. You have Aetna. You have United Healthcare. You have Molina. These are just few examples. You have Cigna. You have Blue Cross Blue Shield. Okay. Now, for the governmental, you have Medicare, Medicaid, Medicaid, Champers, Champa, and then you have TRICARE. Okay. Now, for Medicare, there are some Medicare Replacement. As an actual insurance plan. But okay, so let me explain myself. Let me get a chair. Woohoo. Okay. What I mean by Medicare replacement. Okay, so some of your examples of Medicare replacement is like, how many of y'all heard of Texan Plus? Kelsey Care. Okay, Aetna. Okay, these are your Medicare replacements. Okay, so they use the policies of commercial insurance, but they're using the checkbook of Medicare. Okay, so that's why some of your parents or your grandparents, they may go to the doctor and say, "Baby, all I got to pay is a $20 copay." They got a Medicare replacement. Okay, it acts like an actual commercial insurance, but is really financed by Medicare. Okay, now let's look at this over here. On the commercial side, you have products. Products such as HMO, PPO, point of service, EPO. Okay, you have products such as that. Okay, over here for Medicare, For Medicare, you have Part A, which is for hospital. You have Part B, which is for physician office visit, okay? Part D, which is for pharmacy care, okay? Now, with the Part B, you have a deductible and you have what they call co-insurance, which is the 80/20 plan. And normally their deductible is always $100. After they pay $100, then it's 80/20. Okay. Same thing for hospitalization. They have a deductible, and they also have an 80/20 plan as well. Um, Part A and Part B. So anytime when a patient is seeing a doctor's office, seeing a doctor in a doctor's office, it's always going to be Part B. Okay. Now, maybe I should have written it a little bit better like this. Okay, let me do it a little different like this. HMOs have copay. Okay. PPOs are usually a deductible and a co-insurance and an out-of-pocket max. Okay. Now that co-insurance can be an 80/20 plan or a 90/10 plan or even a 70/30. The deductible has to be met. Is it met? Yes or no? Out of pocket, it has to be met, and then it'll pay the insurance. The insurance will pay everything at 100%. Okay. Then you have, let me write a line up on each one of these if you don't get confused. Okay. Then you have point of service plan. Point of service plan is the best of both worlds. Okay. It is HMO and PPO. Okay. HMO for in-network. PPO for out-of-network. Okay. And then you have your EPO. Your EPO is your exclusive preferred provider. It works like a point of service. I shouldn't say in. It works like a point of service, but exclusive for the employer company. Okay, so let me give you an example, like Randall's Food Market, Randall's, Kroger's, those type of places. They have Cigna insurance, but Cigna insurance may have an EPO plan where they say we only gonna allow our employees to see all Memorial Hermann Hospital physicians and be cared for by Memorial Hermann Hospital system, period. That means they can't go to Methodist, they can't go to St. Luke's, they can't go to Texas Children. They're paying because they're getting such a bulk deal that they have to be exclusively going to that provider, and the plan is exclusively catering to that provider because they're getting a huge discount for exclusively using that provider only. Except the policy is written to where they can pay co-pays like everybody else. They pay a small percentage for MRIs or anything like everybody else. It's just your employer, your boss, whoever signs your check, and give you your benefits of saying, I want all my people, we're going to support Memorial Hermann. We're going to give them all our business. Does that make sense? Okay, so that's how that works. We know that Champa is your military insurance. Okay, how many of y'all are military brats or married to the military or no military brats in here? Okay, my brother is a Marine and his wife is Army. You know, they're vets. And let's see here. Chris is an Army vet. We got some more Army vets in the house. So, you know, that's what I'm saying. They will understand more of this type of benefit. Okay. But just because you're a civilian, you can't work for the VA hospital, other governmental agencies like that. You can't work for those. Okay. Did you have a question, Kayla? No? Okay. Okay. Great. Okay, so this is how it works. So, do y'all have any questions for me on that so far? So I'm going to kind of angle the camera where I can get everything on the camera here, so y'all can see all of that. Okay. And then I'm going to angle the camera over this way. I'm used to having my other one where I could just roll here, roll there. But I don't have that. Okay, so now I'm going to erase all of this and we're going to talk about whose role is it anyway? Okay? All right. This one doesn't write too well. I think I have my purple one in the bag. I'm sorry, we got still writing it?
Oh, no. I'll write that last one.
Okay. All right. And then if y'all need to take pictures, y'all can say something. And I'll let you take pictures of the board. I don't have a problem with that. Okay. So whose role is it anyway? So let me re-angle my camera going back this way. Okay. Okay, great. All right, so whose role is it anyway? Okay, so when the patient makes the appointment, okay, we'll just repeat that. Makes the appointment. This is done by the appointment setter or scheduler. Okay, they make the appointment. So what happens when they make the appointment? They get the patient demographics. Okay, patient demographics consist of name, date of birth, where they live, work, and insurance plan. Okay, now that's what happens. And then once they get the patient demographics, that's if they're a new patient. Okay, now once they do that, then the next person, we're going to put this like in a square. The next person's job would be to verify. Okay, this is done by the insurance verifier. They have to verify the plan. They have to verify 2 to 3 days before the patient office visit. Why is that important? Can anybody tell me why is it important to verify their insurance 2 to 3 days before the patient's office visit? They might cancel. Cancel what? The insurance. Okay. They might cancel the insurance. You're right. Okay. What's another reason?
To make sure, if they are insured, they may have to have procedure done.
They may have to have a procedure done to make sure that they're insured. Make sure their insurance covers that procedure. Very good. You have to also verify to make sure they don't get what? Terminated from their insurance, terminated from their jobs. Usually, your jobs will pay 1 month in advance. So, say, like, if you decide to quit your job today or you get terminated today, your insurance is already paid for the month of September. Okay. If they decide to let you go September 30th, okay, or September 29th, your insurance has already been pretty much paid for the month of October because somewhere in between your 2 week pay period, they've already deducted for the month of October. Okay. So it depends on when they let you go. Okay, so very good. So all those are justifiable reasons for verifying insurance. Okay, so I'm asking whose role is it? The scheduler. The scheduler makes the appointment. They get all the demographic information, and then you have the insurance verified. Now they're going to come in. So they go from here to here, and then I'm writing black. I'm writing black. Okay, now after they do that, now they're going to come to see the doctor, and they're going to see who there when they first come in. The front desk clerk. Okay, the front desk clerk is going to, if they're a new patient, the front desk clerk is going to have them complete all paperwork. Okay, now once they complete all paperwork, then the front desk job next is to collect the copay, okay, or co-insurance at the end of visit. Okay, because a lot of times if they have a co-insurance or 80/20 plan, you're not gonna know how much to tally up for that in order to know what to charge them percentage wise. You would have to catch that after they finish seeing the doctor. Okay, now after they complete all the paperwork, the physician paperwork, they have to also put in the system. They have to also put it in the system, okay? If they are an established patient, what do I mean by established patient? Old patient, okay? You must get them to fill out an occurrence update form. Okay, that occurrence update form is saying, is the address the same? Okay, is the insurance the same? Did your name change? Okay, we need to know all those things. Okay, and this must be done every time they see the doctor. Okay, now after they have completed seeing all of this, now they're going to see the physician. Okay, now number one, well, not number one. What ends up happening is they start seeing the physician based on SOAP notes. Let's do it like this. Okay, S means subjective. Okay, so O means objective. Okay, A means assessment, and P means plan. Okay, that's what that means. This is all dealing with when you're speaking of the SOAP notes, you're speaking of the electronic medical records, EMR, electronic medical records. Okay. Is it raining outside? It sounds like it's raining, huh? Oh man. Oh, sure. Let me get out your way, sweetheart. Sure. Uh-huh. Uh-huh. Okay, now this is talking about the electronic medical records. Now, we're going to talk about electronic medical records at a much later date, okay, in the modules. Now, looking at this, subjective is this is going to be a conversation between the nurse and the patient, okay? The patient is going to tell what is your chief complaint. The nurse is going to take their vital signs. Okay, chief complaint or onset means what brings you in today. That's the chief complaint. My head hurt, my tummy hurt, I don't feel good, and I don't want to go to work. Okay? All right, so then she takes all that down, she leaves a chart on the door, she leaves the information in the chart. So now the doctor comes in, and so now we have a conversation with the doctor and the patient. Okay, so he's going to do his review of systems. He's going to look at your chief complaint. He's going to also look at your vital signs. Okay, and so once he look at your review of systems, that's what ROS means. ROS means review of systems. Review of systems. How many systems of the body are there? You have the pulmonary, you have the integumentary system. Uh-huh. Uh-huh.
I just like 6 or 7.
12.
Oh,
Yeah. 12 systems of the body. There are 12 systems of the body. Okay? 12 systems of the body. Well, it's in there. It's in there. So if he's talking about, if the patient comes in and she says, my head hurts, I have a stuffy nose, What else am I
A
feeling?
fever.
Huh?
A fever.
And a fever. What areas of the body will the doctor check?
Heat.
Okay, that's the nervous system. Okay, and then he got a runny nose, feeling congested.
The mouth.
Well, kinda. He's gonna check the ear, nose, and throat.
Yeah.
Okay, ENT. Okay, and that's another one of the systems. Can't get it right now. And then he's gonna also check the respiratory system, see if he has bronchial issues or acute bronchitis or something like that, or a sinus infection. So he's checking 3 out of the 12 review of systems. That's what he's doing. And so he's documenting, okay, I checked her head, she's feeling like this, I think it's that. I checked her chest, it sounds clear, however, it's a little bit raspy, she may have bronchitis. I checked her nose and her ears, and it's red, so she may have otitis media. So I'm gonna give her some Bactrim or some sort of antibiotics to try to help clear up your problem. Okay, and some Robitussin, some kind of strong cough medicine to kind of help clear up your problem. And then he'd probably prescribe you to get some over-the-counter medicine, which is like Theraflu, okay, or some Mucinex, okay. All right, so now after he does that, now he's going to tell you, the coder, what his problem is, diagnosis code, and what he did about the problem, procedure code. So this means diagnosis code. This tells the problem of the patient. What's your problem? You got a headache, and I don't want to go to work. Okay. PX means procedure. Okay. Procedure code. Okay. This tells what the doctor did. Okay. Meaning that he saw the patient. He saw the patient for 15 minutes. He did a CBC. He did a urinalysis. He did a chest X-ray. All these are going to have procedure codes. Okay. Now your diagnosis code will have an alphabet. Okay, and then 1, 2, and then a period, and then 1, 2, 3, and then sometimes a 7th digit. First, second, third. Then this is what matters. This decimal right here. Either it's a 4th, either it's a 5th. I'm gonna come back to it. Either it's a 6th, and I call the 7th anchors. Okay, anchors. And I'll tell you why. Or placeholders. There you go. That's what they're called, placeholders. Okay. Now, procedure codes have 1, 2, 3, 4, 5 digits. Okay. All right. Now, this right here in the assessment, this is where we medical biller and coders live in our job all day, every day. All day, every day. This is where we get our business right here. We have to know what is the diagnosis code, what is the procedure code. Only the doctor, only given by the,
Like once they get them.
then come down here, the front desk will bring it to you. I'm gonna explain that in a minute. But yes. Then right here, this means RTO, return to office in 2 weeks or more. Okay? That means prescription at HEB, at his local HEB, wherever he goes to get his prescription. Okay? So again, subjective, objective, assessment, plan. Where does our work live at, ladies? Assessment. When they're going to take it back to the front desk, the front desk people are going to close out the day. How do they close out the day? You know how they check people in, right? So now they got to say, okay, all these patients that were seen between 8 a.m. and 12 noon, we're closing them out. All the co-pays was collected. All the co-insurance was collected. Okay, now it's 4:30, and we've seen our last patient before we close up at 5 o'clock. So I'm going to close out every patient from 1 to 5. Okay, because we got the last patient. We're not going to take any patients at 5 o'clock because we close at 5. We taking the last patient at 4:30 because we want to get out of here from 5, right? Or maybe 5:30, just depends. So you closing all those out. So now you take all your stacks of paper and you're going to bring those stacks of paper to the medical coder. Y'all got it? The medical coder, sometimes medical coder is the medical biller. And sometimes the medical biller is the medical biller by herself. Sometimes the medical coder and biller is one person. 2 jobs with 1 person. Does everybody hear that?
Yeah.
Okay. So the front desk clerk is going to say, here's all my closed out cases from today's office visit. I'm going to hand it to you. Okay. She hands it to the coder. The coder goes back. She review all the codes, make sure all the codes is correct. Sometimes the doctors or the nurse may not know exactly what code to pick. You see those type of patients all day, every day, 3 and 4 times out of a week. And it's kind of like a routine. And then there are some, they're going to have to kind of like go in that ICD-10 book or go in that software, kind of like, let me put this code in. Oh, yeah, it's that code. Let me write that down. Okay. Yeah, that's what our problem is. Okay. But the coder has to make sure, okay, how long did the doctor see the patient? Because the doctor may write 15. The doctor may write 30. The doctor may write. So that means it brings a different level. So a 99201, we're going to learn what evaluation and management codes are, surgical codes, pathology codes, radiology codes, your medicine codes. We're going to learn what all those codes are in the CPT book. Okay, your CPT book tells what is the problem of the patient. I'm sorry, what the doctor did about the patient. I saw the patient for 15 minutes. That's what I did. Or I saw the patient for 30 minutes. That's what I did. I told the patient, I gave her some orders to get a CBC done. I gave the patient some orders to get a prescription to go get a chest x-ray done because she sounded a little raspy in her chest. Okay? That's what the doctor what? Did about the patient. Okay? I did all the review systems. I only checked 3 out of 12 complaint did that. That's now telling me after evaluating and seeing what and checking her breathing and everything and looking at her, that tells me that she has bronchitis and she has migraine headaches. So I'm going to give her some prescription. I want her to come back and see me in 2 weeks or a week or next month. And I want her to go get some medicine over the counter, or I'm going to send her a prescription electronically to HEB. Does everybody understand that? So when the front desk person has to close out every appointment scheduled for that day. We have to give an account. Why? Because when we give it to the coder and they set the codes right, the patient, and then he's going to read all the notes of what he said about the patient, and it has to check and balance with that, the procedure code. You just can't randomly name a code off the bat. And when we get ready to learn about basic coding and stuff for CPT and diagnosis coding, you'll understand exactly what I mean. Okay, and we have to double check for audit purposes because billers and coders can get audited at any time from the government, anytime. And so it has to make sense. The documentation in the electronic medical record has to make sense. Does everybody get that? It has to make sense. Okay, now the coder does all of her job. She double checks the code. Now it's time for her to give it to the medical biller. The medical biller will take that information from that day and put it on a CMS 1500 form. Can I see your handbook, sweetie? I'm gonna tell you, it's not your workbook. Okay, yeah, this is your handbook. In here, they have a CMS 1500 form. So I'm gonna show y'all what that looks like. Okay. Okay. So on page 258, 259 is an example of a CMS 1500 form in your book. 258, 259. Okay. Now electronically, 258, 259 in your handbook. Not your workbook, your handbook. It's okay. In your red handbook, this one here, baby. You had the right one.
I didn't.
Oh, you didn't bring it?
Yeah, it's a workbook.
Oh.
Huh? Is that one? Oh, yeah.
Bless your heart, baby. Bless your heart. 258.
Oh, sorry.
Okay, it's okay. It's okay. All right. So this is a 1600 form. Okay. This form is only used in a physician's office. Okay. Now, sometimes they will use this in a home health agency. Sometimes they will use this in a physical rehabilitation center, like someone that does physical therapy or occupational therapy or respiratory therapy. Sometimes you'll find these useful in that, but never used for hospital billing, only for professional billing. Now, you use this also when the physician is making rounds in the hospital and he's seeing the patient in his or her room for like 10 or 15 minutes. You have to put down, and the hospital will let you know, that your doctor came by Saturday, your doctor came by Sunday and released the patient on Monday. Your doctor said that he spent 15 minutes evaluating the patient before they discharged them from the hospital. You would then put his services of work on here. As far as the UBO4, the UBO4 is used for hospital billing when you have to charge for all that food they eat 3 times a day, sleeping in that bed 3 and 4 days out the week, or 2 weeks or 3 weeks in there, using that cup machine, using the pillows, using the pajamas. You want that $30 Vicodin every 4 hours, or that morphine shot every 2 or 3 hours, or as needed. Okay, they charge the surgery that costs. All that goes on the UBO4, and they have what they call revenue codes. That's a whole different form. This form is for professional services. So you're probably wondering, okay, well, if Dr. Smith made rounds to see Sally Sue at the hospital Saturday and Sunday and released her, discharged her from the hospital on Monday, what am I going to put on here? I'm glad you asked. Right under here where it says place of service code, look in that area where it has those 6 lines. You put today's date, right? And then 24B, place of service, 24B. You see what says 24B? You're going to put place of service code 21. There is a whole list of codes that's in